So we will now have our keynote speaker, Dr. Bret Betz. He is an associate professor in emergency medicine and orthopedics at the University of Cincinnati College of Medicine. He's a team physician for the Cincinnati Bengals, and he was part of the medical team that resuscitated Damar Hamlin after his cardiac arrest on the field. He also serves as the medical planning committee for the Cincinnati Marathon and has a passion for teaching emergency sideline management and improving sideline medical care for athletes. Please join me in welcoming Dr. Bret Betz.
Thank you. Thanks for that intro. We'll get through this. Thanks for allowing the virtual conference and allow me to get home, or allow me to not fight to get home this weekend from the white snow and the blizzards that's coming through the Midwest. So excited to talk to everybody. We'll probably hold questions towards the end. We should have a little bit of time at the end for questions and hopefully can answer everything you guys have questions about. But so today we're going to talk about emergency sideline preparedness and cardiac arrest in athletes. Um, these two topics really came to light from this event, the collapse of Damar Hamlin on January 2nd in 2023, which happened on our home field while I was working with the Cincinnati Bengals. And it was really the team and the preparedness of those around that I think led to his outcome. And so I'm going to talk a little bit about that today. We're going to talk about sudden cardiac arrest in general in athletes, a little bit of the background with that, as well as how to identify cardiac arrest in athletes. We're going to talk about the NFL response and emergency action plans, some of the action plans that were in preparation that day of the collapse on January 2nd, and all the resources that we have. And I'll bring this to light. I know that a lot of us work on high school sidelines, college sidelines, middle school sidelines, things like that. And the NFL has a lot more resources, but hopefully going through this, you can take little things to really kind of enhance the preparedness as you go through all levels of sideline care. And then we are going to go through a little bit about the case of Damar Hamlin and really some general kind of lessons learned. And so, if we talk about sideline medicine, this is something I'm really passionate about. I'm sure you all are as well as emergency physicians. I think we're uniquely qualified to be sideline physicians. I think sideline medicine is it's a unique field. It's even different than the emergency department. But when you talk about acute injuries, when you talk about stabilization, when you talk about EAPs and preparation, working with EMS, I think we have to take pride that our background really allows us to be really the forefront and the leaders in sideline medicine. And so when we're teaching sideline medicine, or when I'm teaching sideline medicine to athletic trainers or fellows, residents, I really like to think of what can harm the patient acutely. So if we're talking about acute emergencies, I try to simplify that differential diagnosis into either the three or four H's, and that's heart, heat, and head. You can add hemoglobin or hemorrhage, sickle cell trait in there. But if we think of these three or four H's, they're really going to encapsulate about 95% of what is going to acutely injure or cause significant harm to our athletes. So if we go through heart, obviously we're talking about cardiac issues, sudden cardiac arrest. If we talk about head or high C-spine, we're talking about intracranial hemorrhage, TBI, cervical fractures, and then of course heat for heat stroke. So I really try to think of the three H's, head, heart, head, heat, as you're going down your differential. Because each of these has acute, different pathology that can harm the athlete, and they all have different treatment pathways. Cardiac issues have really gotten a big or more presence, more time in the media, and that's because we've seen a couple big names in the past 5 years, namely Christian Eriksen, that was in 2021, the Damar Hamlin case in 2023, and then later that year in 2023, also Bronny James. And so we've seen a lot more and more of these in the media, and the focus has changed to, acute care and acute cardiac care and resuscitation. And because of this, I'll say I think we've seen a lot more emergency physicians on the sideline and a focus on emergency care for our athletes, all for the better. So if we take a step back and talk about sudden cardiac arrest in athletes, we first want to define it. So sudden cardiac arrest, you have to know whether you're talking about, if you look at studies, sudden cardiac arrest as an event or sudden cardiac death. But it usually is either death or arrest due to cardiac causes or if there's no other explanation. This patient population is going to be usually under 35 years of age. That's because once we get to over 35, there's usually other causes, normally cardiac or coronary artery disease. It's usually while exercising or within 1 hour of exercising. And then, so therefore, it's more exercises associated sudden cardiac arrest. So when you're looking at data or studies for this, it's important to know whether it's exercise associated or just sudden cardiac arrest in athletes. And so if we look at the data for sudden cardiac arrest in athletes, it is a little bit difficult to actually define the numbers. And that's because the numerator and denominator is sometimes difficult to find. One, there's no national registry that mandates reporting for sudden cardiac arrest. We're getting better at reporting, and there are agencies that track this, but there's no national mandatory reporting. Also, the denominator essentially can change, and it depends on the number of athletes participating and things like that. But certain studies, and this is a study from the NCAA in 2015, showed that about 1 in 50,000 athletic years in college athletes, there's an incident of sudden cardiac arrest. High school athletes, that's a little bit less, to 1 in 50 to 80,000, and that results in about 100 to 150 deaths a year. There are certain populations that have a little bit of a higher rate, including males, basketball players, and soccer players. And that rate in basketball players is thought to be a little higher, which with about 1 in 9,000 athletic years. And if we go over the causes of cardiac arrest or cardiac death in athletes, there's structurally normal heart, there's structurally abnormal heart. The structurally normal heart are the things we typically hear about, right? The Brugada, the things we worry about in the emergency department, long QT, commotio cordis, things like that. And then the most common structurally abnormal causes are going to be your hypertrophic cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy or ARVC, as well as autopsy negative cardiac death. And so this is a big thing that I want to kind of harp on is the actual presentation. And so the presentation of cardiac arrest is in our athletes is usually going to be the first sign of illness. And I will say that these can look different. So working in the emergency department or in the hospital, it's a different presentation. That slow septic patient that slowly goes into cardiac arrest. These actually, you can see posturing, you can see increased tone, you can see jaw clenching, biting of the tongue, and it can almost look like a seizure. So one of the things that we teach is that anytime there's an athletic collapse and you think it's a seizure, you have to roll out cardiac arrest first. They can be breathing spontaneously as well. And so this is a video. This is courtesy of John Dresner. But essentially, I want you to think about this is the face of sudden cardiac arrest. And I'm going to play it here. There might be some sound, so hopefully that's not too loud for people in the eyes. But if you look at the center there, the non-traumatic collapse, this is Fabrice Mamba in 2012. And this is in a Premier League match. They're going to zoom in here. Okay, if you can see, he looks like he's breathing spontaneously. His eyes are open. Clenched jaw. He's got some tonic-clonic movements of his arms, potentially in his legs. The other thing you can see is that when these happen in an athletic participation event, there's a lot of eyes. There's all kinds of people around, and so that's part of the difficulty with all this as well. But as you can see, as they go through this, they do quickly identify that he's in cardiac arrest. They'll start CPR here. They'll start chest compressions right here at about a minute and 10 seconds. And then they apply the AD. And if you went through this video, you'd see they shock him, they transport him. He actually survived. He did require multiple shocks en route to the hospital. He actually retired from after this event, but did survive. But I want you to take that away as far as this looks different. So again, the clenched jaw, potentially tongue biting, eyes open, spontaneous breathing, can all be cardiac arrest. And this is a great video. This is a plug for a video. This is John Dresner. This is online. You can look up YouTube, How to Save a Life, but it goes through these cases and some other cases that are seen. So we talk about sports-related sudden cardiac arrest. This is nearly 40% in people 40% of cardiac arrests under the age of 18 are sports-related. So that's a higher incidence in athletes. It's about 2 to 4 times higher than the general population. So there's a little bit of a paradox there, in that it's happening potentially more frequently in our athletes. And this was actually studied, and the overall thought is that it's not actually sports that causes this, but instead, they're athletes with a pathologic substrate, and essentially the cardiovascular conditions kind of predispose these pathologic substrates into ventricular arrhythmias during physical exercise. And so the thing we know is that most of these athletes will actually have VFib, VTAC, or a malignant arrhythmia. And the good thing is that we know how to treat that, right? The key is the recognition, as we talked about, or teaching our athletic trainers, teaching people on the sideline how to recognize this, good quality CPR, and then AED use. And so if we talk about AED use, this is one of the first or biggest published studies on AED use in high school. This is a Dresner study in 2013. They looked at 2,100 high schools, 59 cases of sudden cardiac arrest, 26 students, and 33 adults. And they had astonishing rates of success with this. Now, 93% of these cardiac arrests were witnessed, which is a big key factor. 2/3 had shocks delivered, but what they found was that about 89% of adults exercising, as well as in student athletes, actually survived cardiac arrest in these high schools and in these cases. What they found were that survival rates were higher in schools with an established emergency action plan than those that didn't, and that was about 80% versus 44%. And if they use the on-site AED versus one provided by EMS, again, it was about 80% versus 50%. This is a more recent study. This recently came out this year. This is from 2025, but it was a retrospective study as well, looking at a national registry for catastrophic injury. They looked at a little over 600 cardiac arrests in middle school, through college, through professional. Their survival rate was about 49% overall. But what they found was that exertional sudden cardiac arrest in these athletes was about 50% survival rate, and non-exertional was 27%. So lower, obviously, when they weren't in athletic competition. Lower survival rates also were with black race or other races. And then if they were in a practice versus a game. And that makes sense. Practice, less people around, maybe not an athletic trainer around, versus a game where we have much, much more resources. This data for AED use and defibrillation is also in our EM literature and our EMS literature. This is a study from 2015 in resuscitation. This is from the CARES Network in North Carolina, and they did a 3-year retrospective look at about 17 cases of defibrillation. Again, this is all comers, though. This is not just athletes. What they looked at was time to defibrillation and outcome. And what they saw was, what we all know and think is that quick defibrillation, timely defibrillation, leads to better outcomes. And what they found was that there was a 60% survival rate if an AED was used or defibrillation was used within about 2 minutes. Also, you can see the survival rate decreases if EMS are the ones to defibrillate the patient as time goes by. And so this is a similar data and just a different graph from this paper. But what you can see is that around 2 to 3 minutes, we do see a pretty significant drop in survival rate, and it's about a 10% decrease in survival per minute when per minute of lack of defibrillation. And so this is when you see the data of trying to get a defibrillator to an athlete in the first 2 to 3 minutes and defibrillation used. This is what we're basing that data off of. And so if we talk about preparation, which is really one of the big keys to the sideline care and the care of these athletes, we do need to think about all the parties involved. Obviously, I think most of us in this conference are physicians, if not all. But there's a lot of parties involved in the survival of these athletes. One big one here, our athletic training staff. They're going to be involved significantly in emergency action planning with your EAP, with the treatment, your EMS, so your local EMS, whoever's going to be at the game or respond to the scene needs to be involved in preparation as well. And then coaches, teachers, even athletes themselves. To the right here is our coaching staff going through CPR training. Because a lot of times we are not going to be there. If you quote that Dresner study, 93% of those athletic arrests were witnessed. But the fact of the matter is that we as physicians likely won't be there. So we need to include and train all of these parties for this. The other thing, just thinking about coaches and trainers and staff. One thing in Cincinnati that we've done, there's the Matthew Mangine Foundation that actually goes to high schools and does hands-only CPR training with teachers and with coaches. And that's, again, through Take 10 Cincinnati. And I think Heidi is going to talk a little bit later about a program in Buffalo that's similar. If we talk about emergency action plans, I think we all know pretty much what this is, but it's approach to really any medical emergency at a specific venue, whether that's head, spine, heat-related issues, cardiac arrest, things like that. Big thing is location of AEDs. They should be within about a minute to 2 minutes from where the cardiac arrest or the event could occur in order to get that AED and get it back on the athlete, making sure they're not behind locked doors. A couple of the other things we think about are who calls EMS, who's crowd control, is the ambulance going to come on the field, what are the ways to get off the field, what hospital are they going to go to, things like that. As far as the NFL goes, we have it pretty laid out. We have specific things we need to get to meet and requirements that need to be met for our emergency preparedness. But essentially, our emergency action plans are reviewed by the NFL and the NFLPA, and they approve them. One of the biggest things that I'll talk about later too is that our medical staff, we are required to rehearse the EAP every year. We actually do it twice, and we'll talk about that in a little bit. We all have a level 1 trauma center where we designate our athletes to go if there is an acute emergency. And then we have EMS on the sideline. We have 2 EMT and paramedics, often 2 ambulances right on the sideline only for athletic care. The other thing that's very unique to the NFL are probably the number of personnel that is on the sideline. We're very lucky in this. We're very lucky with the support, but we have, multiple orthopedists, we have multiple primary care physicians, athletic trainers on the sideline, and then there's a whole independent kind of medical staff, both for concussion work as well as emergency response, and we'll go through that here in a little bit. But you can think about it essentially like a trauma bay. Everybody's waiting for something to happen. So very lucky in the NFL for what we have. If you look at the NFL game day medical team, I like to think about it like this. So we have team physicians, we have athletic trainers, but then there's the independent side. There's the concussion management side where we have UNCs, we have ATC spotters, but then there's the emergency response team, and that includes an airway management physician. It used to be called the VTML or the visiting team medical liaison. That is now an ER physician or an emergency medicine physician that's called the emergency response physician. We have medics, we have respiratory therapists, and then we typically have two ACLS ambulances. And so that emergency response team was present and active and in this resuscitation and was activated essentially during this resuscitation of Damar Hamlin. And so it all just didn't start that, when you talk about the emergency action planning, it didn't just start out of nowhere. It actually evolved and, through changes, through review, more and more was added on. So that started in 2003 with the airway management physician program. They assigned a airway physician, either an EM or an anesthesiologist, to essentially be on the sideline in case of an acute airway issue. That evolved then into 2013, where emergency action plans were reviewed by an independent expert. In 2015, the visiting team medical liaison was started, and that individual was usually an EM physician used to kind of be again, liaison when a visiting team was in. They would provide medications, help them out with which hospital to go to, coordinate things like that. In 2017, the 60-minute medical meeting was introduced. In 2019, we were required to actually undergo training and go through scenarios regarding our emergency action plan. And then it just progressed as it went on. Okay. And we'll go through a little bit of those changes, but this is mainly to say that it all didn't start overnight. And through review and reviewing cases, it grew and grew. So if we go through the airway management physician, so the airway management physician is typically an EM physician or an anesthesiologist, and they really have been around for a while in the NFL, and they're responsible for acute airway emergencies. They do have to meet a certain level of intubations and trauma one level intubations every year. And so it's an active participating EM or anesthesiologist that is used to these kind of complex airways. They really bring the emergency department to the sideline as far as having video laryngoscopy, portable suctions, all kinds of other oral airway adjuncts, and medications then for sedation for paralysis. And this is Woods Curry here in the red hat. He's our airway physician, a classmate of mine from our residency program here, and he was highly involved in the resuscitation of Damar Hamlin that evening. The other person that's responsible is another EM physician, again, independent on the sideline, and it's called the emergency response physician. This actually replaced the VTML program after the Damar Hamlin incident. Initially, the VTML program, as I said, was more of a liaison to visiting teams, would deal with medication, trying to get a patient to the hospital or the emergency department and smooth that over if needed. But after the events of Damar Hamlin, they realized that you probably needed multiple people involved. And multiple EM physicians involved. And so this actually became a more global kind of emergency response role after that event. And essentially was designated usually as the code leader. And as we go through this, I'll hence the importance of identifying a code leader prior to any of these events happening. One of the most important things I think that was implemented in 2019 was actually having to go through, train, and rehearse our emergency action plans. During this, so we do this every year. We do it in the summer. Usually we do it in June or July, and then we do a second rehearsal on our own. But this is done by a third party that comes out to our facilities. and we do different simulations. And one of the keys here is that everyone is involved. So all the EMTs are there, all the airway docs, all the emergency response physicians, our orthopedic physicians, everyone is there to go through different scenarios and rehearse. And then we debrief. And I can tell you that every time we've done this, every single year, we change something or we maybe realize something needs to be improved or there's a flaw here. And it's the importance of really getting together and practicing and going through all of this. We go through different game day scenarios with this, including spine and head trauma, heat illness, cardiac arrest, truncal trauma, things like that. And then there's also practice scenarios where we as physicians aren't involved because we're not usually there, and the athletic training staff goes through it with the EMS personnel. The other thing important that a lot of people didn't realize was that the same year of the Damar Hamlin arrest on our field, a few months prior, was actually a very prominent event where a Dolphins quarterback had a pretty significant head impact and had seizure-like activity, posturing, and was unconscious for a brief period. But what this allowed us to do was actually rehearse our EAP. So essentially, there was an all-call, and airway management physician was out there, but we were able to review this. We did a review afterward, and kind of improved some of our processes as far as exiting the field, as far as who would call up to the hospital. And so I think that really helped play out in the events later that year. Another very important thing, I think, is this 60-minute medical meeting. So this is a meeting held 60 minutes before every game, where all the team medical staffs get together. So visiting team medical staff, EMS, all the independent providers that are on the sideline, we all get together and essentially go over the emergency action plan. Everyone introduces themselves, everyone goes around the room, and we talk about who's going to be the code leader, which is really important for that day, where people will be transported to, depending on their injury, how far away, how they're going to be transported, and really just run through the emergency action plan. The other thing that there is in the NFL now is a 90-minute meeting, where EMS and our emergency action team gets together, reviews medication, goes through the bag, all in preparation for game day. So this isn't just unique to the NFL. This is actually a high school Friday night medical timeout. This was put out by the Kyle Group, and it's endorsed by the Corey Stringer Institute. And this is essentially the same thing. It was going on before the NFL instituted it, but it's essentially a medical timeout that should be done before a high school event where a visiting team comes over, medical personnel, and you just go over who's there. And I think this is really important when you talk about the first time you don't want to meet someone is on the field during a significant event. You want to know kind of the different protocols, where you're going to go, and things like that. And so this has been actually mandated in certain states. It's definitely mandated in West Virginia. I believe it's mandated in Texas. And then there has been a push to implement this in other states as well. And so we go through the events of January 2nd, this is a video here. And so that's T. Higgins crossing the field. And some of you may have seen this, but what you see there is the non-traumatic collapse. Okay.
What any of us want to see, and everybody's around him, and just hope that he's going to be okay. So we'll take another break here in Cincinnati.
And so what I'll say with that is that the Bills medical staff, obviously watching their player and understanding their player, acted immediately. From my vantage point on the sideline, I actually didn't even see it happen because I was focused on my player. I was focused on T. Higgins crossing the field and saw that he got up and was looking around at the other players. But the Buffalo Bills medical staff acted immediately, activated the emergency response team all-call event, which got our airway physician out there, which brought the VTML out there, and which brought all the equipment out there. And so it was really the quick action, the removal of equipment, and the acute response by the Bills that really brought that whole team out there. So in this event, CPR was initiated, Damar was defibrillated, and then he was moved into the ambulance. It was always our plan to bring the ambulance on the field if there was a significant cardiac event so that everything could be handled and all of the equipment was out there if we needed additional equipment. The resuscitation was run by our airway management physician, Woods Curry, with the assistance of the VTML that night, Jason McMullen. And it just so happens that our UNC that night as well was an emergency physician, Robbie Paulson. And so there were essentially 4 emergency physicians that night, as well as our EMS personnel, our respiratory therapists. And we were really lucky to have that entire team there. So Damar was taken off the field. The plan was always, if there was going to be an intubation, it would actually be done off the field in the ambulance if possible. And so he was intubated and then taken to University Hospital. And so I can't talk a ton about, obviously, the details, all of that. Those details have already been talked about in the media. But kind of looking back on this, I think one of the biggest things about this I think of is crew resource management. And we all talk about it in trauma resuscitations and things like that. But these can be very chaotic situations, and no doubt they will be chaotic. But I think the key is really having a leader, knowing who that leader is, clear, concise communication. That leader was Woods Curry that day. And what I can say is that his clear communication that day and essentially decision making really kind of led to the outcome. So if we think about that, we think about crew resource management, we think about someone leading who has an overall view and an overall picture of everything going on, not doing too much at once, but putting someone in command and a co-leader that actually isn't doing medial tasks and making sure everyone has a role. I think that was one of the most important things that day. I think it was also important to have a plan and stick to it. So know your emergency action plan, know who's going to do what. One of the things that we had always talked about was whether to intubate on the field or off the field. Our plan and our emergency action plan, it was always to stabilize the airway and then have the ambulance on the field and then perform that procedure in the ambulance. And that can be different for anybody, any scenario. But other questions you can think about is, it's the small tasks of who's going to start the IV, who's going to take control and hand equipment out, who's going to hand medications out, who's going to be in charge of crowd control, how long are you going to stay on the field, are you going to do a certain number of rounds of CPR, are you going to switch over to a Lucas device, all things like that, but at least having a plan and sticking to it. And then finally, I think, knowing your crew and knowing who you have around you is really important as well. Definitely for this. We were really lucky in this scenario because we had all worked together. We all work at University of Cincinnati. The 4 EM physicians that worked together, we'd all been attendings or fellows or residents and had done this many times. But even if you translate this, to the high school sideline and things like this, I think that's why it's really important, really to know your EMS team, or at least before the game. What we always tell our fellows is introduce yourself. That's why the 60-minute meeting is important, or a medical timeout before the game, to just know each other, know the different roles, knows who's going to do what before an event like this happens. And then what's come of this, really, we've seen a lot of different pushes, especially in state legislation, funding nationally for this. We're seeing a lot more mandatory AEDs, mandatory emergency action plan. Some states are actually making it mandatory that emergency action plans are rehearsed. And so a lot has come from it. The NFL has started to put some funds into this as well. And so, in conclusion, I would just say that I think we are very uniquely prepared for this. I think we can be leaders in this. I think sideline medicine is different. And I think we should be proud that, in my mind, emergency medicine equals sideline medicine. So thank you.
Thank you so much. That was a great talk. Do we have any questions from the audience or online? All right, we have a question.
It's amazing that NFL has all these resources and they just love and continue to add to their team. To speak to most of the fellows here today who might be thrown in to high school that they've never been to before, or even if they are teaching for high school, what would be your kind of top 3 to 5 things that you would recommend? Same day preparation.
So for the audience and for Brett, what would be the top 3 to 5 things for preparation, especially with different levels? With the NFL, they have a lot of resources, but down to high school and college.
Yeah, so I think you definitely, when you're talking about high school, which is probably going to be your least resource driven, it depends on the high school as well. I think the biggest thing is knowing where your AED. It comes down pretty simply to knowing where your AED is, having one on the sideline if you do during your practices, and making it, if you don't, making it close enough. So it should be within that 2-minute mark. So the AED is the key. And then I think training your coaches and teachers, if you can, going through some kind of program where training them the recognition of sudden cardiac arrest as well as CPR is huge. Because so many of these events, especially in high school, which is where most of them are going to occur, right, are actually going to be on the practice field and they're going to be with a coach. And that's where we see a lot of the delays in care. So really AED and trying to train your staff and then knowing where what your EAP is and letting them know kind of how that works.
Yeah, I just wanted to come up here just so I could get to a microphone. But the one thing that stood out when I went through your slides earlier was that if you look at just overall, like you're looking at outcomes, having an emergency outcome plan improves survival. And that's the most important outcome. And I think there are a lot of confounding factors there. And one of that is like, if you have a plan, you probably have an AED or you need to get one. So I think that there are things that go along with that, but just having a plan, practicing that plan, most important things you can do. And that's, I think, the main takeaway I got from going through yours.
Absolutely.
And a couple questions we had from the audience online. So do you mind explaining the transfer of care between EMS and the physician team in the ED in such high acuity incidences? Do the physicians hand over the care or do they maintain contact?
Yeah, so I'm going through so this is in the emergency department. I'm sorry. On the side, gotcha. Yeah.
Sure.
So yeah, so as far as on the sideline, whether to hand over care from the physician to EMS, I think that's independent of kind of your decision. And again, that can be a decision for your emergency action plan. I can tell you with the Bengals, our plan would be, and it is, that if there was a cardiac arrest, I would go with the patient, but also we have physicians on the sideline, like you said, those emergency independent physicians as well. And so I think it depends on you and your team. It depends on the comfort of your EMS team, especially at the high school level. But I think typically you would have a physician go. But again, it's dependent on your EMS system.
And then there's a question about eCPR. So were there any discussions about eCPR activation, if that is available, given that the patients in the NFL are young and healthy, and or is this left up to the ED team upon arrival?
That's definitely left up to the ED team. I can tell you in events like this, everyone will go to the emergency department, even people you didn't ask or invite to the emergency department. And so cardiologists are going to show up in the ED and things like that. But I think it's all just driven on your protocol at your hospital.
Awesome. And I think we have one more question. Does the NFL publish any of their EAPs or outlines with role descriptions so that they can use for templates in other levels of treatment?
I'm not sure if they're actually published anywhere. We do have access to them. But I'd be happy to kind of share if anyone has questions about an EAP or anything like that. This is my resource. But there are multiple good examples, especially on like Corey Stringer Institute and things like that of really, really good EAPs. And I can tell you EAPs, it doesn't have to be long. It doesn't have to be incredibly specific. I've seen very short EAPs that are good. It's mainly that you're hitting your key aspects.
Awesome. All right. Thank you very much, Bret.